Welcome to Lesson 4, where we will be reviewing trauma and other stressor-related disorders. And the verse guiding this lesson is from Isaiah chapter 41, verse 10. Fear not, for I am with you. Be not dismayed, for I am your God. I will strengthen you, I will help you, I will uphold you with my righteous right hand. Trauma can have many definitions, and in mental health, we are looking at the experience of a trauma as something that is sudden and it has a threat to the life or physical integrity of the individual. And it's something that occurs outside of normal experiences. And there are two different types of trauma, such as a exposure to a single event versus long-standing or repeated exposure. Now, in previous editions of the DSM, type 2 or long-standing or repeated trauma was conceptualized as perhaps contributing to the development of a complex PTSD, and possibly even the development of chronic PTSD. That has been changed in the DSM-5. So in the DSM-5, we are just looking really at one definition of trauma. In the DSM-5, PTSD was given its own category, trauma and other stressor-related disorders, where previously it was considered an anxiety disorder. And there previously had been a subjective reaction criterion for the development of PTSD, in that they needed to experience a traumatic event, which was an event that involved actual or threatened death or serious injury, or a threat to the physical integrity of oneself or others. And the subjective feeling that was required was that this was accompanied by a feeling of intense fear, helplessness, or horror. So that was required. Now, it is recognized that an individual may not experience that at the time of the trauma, perhaps due to some defense mechanisms, and they can still develop PTSD. So evidence did not support the need for that to make the diagnosis. And as well, DSM-5 allowed for the traumatic events to occur not only by direct exposure, but also by witnessing the traumatic event, but also learning about a traumatic event that happened to a close family member or close friend. So that has been expanded as well. First responders that have extreme and repeated exposure to aversive details may certainly meet criteria. And that excludes exposure through the media unless it's work-related, such as police officers needing to view pictures of assaults and things like that. And in relation to children, an important addition to the DSM-5 is the new criterion, negative alterations in cognitions and moods associated with the traumatic event. So previously, we just had the three constellations of symptoms: intrusion, avoidance, and arousal. And now we have the mood alterations as well. There was additionally a subcategory for PTSD for young children, children 6 years and younger, as there are some important considerations. And so for the diagnosis of PTSD in children aged 6 and younger, instead of 7 symptoms, only 3 are required. 1 from intrusion, avoidance, or negative cognitions or arousal. And that's important because we know that that without treatment, PTSD can become chronic. So we really want to have early identification and intervention for children with exposure to trauma. So trauma is actually quite common, and about 20% of children may develop PTSD after a traumatic event. And as said previously, untreated symptoms can become chronic. So treatment is important, yet careful consideration of treatment is necessary because some types of therapies can be re-triggering and actually make PTSD symptoms worse. And so it's important to start with um, instruction in the area of relaxation and um, as well to ensure that the child is in a safe place before embarking on any kind of trauma therapy. Exposure to traumatic events in children can lead to a number of different reactions that can range from relatively mild, causing little disruption in the child's life, to severe and debilitating consequences. Most children and adolescents that are exposed to traumatic events will develop some psychological distress, which is generally short lived. And we can consider an adjustment disorder diagnosis in these cases. In some cases, however, symptoms do not remit spontaneously and instead become clinically significant, persistent, and impairing. And reactions to trauma exposures are defined according to their time frame, either immediate or peri-traumatic reactions, and that can be lasting anywhere from minutes to hours. And then we have another commonly utilized diagnosis, acute stress disorder, or ASD. And with ASD, the symptoms last between 2 days and 1 month. And then, of course, with PTSD, the symptoms need to persist for more than a month. Children and adolescents can have a number of reactions to the traumatic event, and this can develop into additional comorbidities as well. So, children and adolescents can develop other psychiatric conditions, such as depression, a panic disorder, or specific phobias, as well perhaps behavioral problems such as oppositional defiant disorder, trouble with attention, and as well may have a loss of previously mastered skills or the experience of regression. It is estimated that acute stress disorder can occur in around 8 to 10% of children exposed to a stressful or traumatic event in industrialized countries. And the rates are somewhat lower than in adults. So an average prevalence of 17% is reported to be the average for adults. And for PTSD, the estimate is between 7 and 10% of individuals may suffer from PTSD in their lifetime. And the 12-month prevalence is 4%. And a large epidemiological study in the US found a lifetime prevalence rate for PTSD of 4.7% among adolescents. And just like with adults, the rates are higher with females than with males. When confronted with a traumatic event, most children and adolescents will have an immediate psychological response. And reactions that are experienced during and after trauma are called peritraumatic. And these are robust predictors for the development of PTSD. There are two types of peritraumatic reactions. The first we'll talk about is peritraumatic distress, and this is where the individual feels fear, horror, helplessness, sadness, guilt, shame, fright, loss of bowel or bladder control. And then there is the peritraumatic dissociation response. Dissociation would be described as blanking out, feeling like they're on autopilot, a time distortion, depersonalization, derealization, experience of confusion, amnesia, or some type of decreased awareness. So, early psychological reactions to trauma exposure are described as an acute stress reaction in the ICD 10 and acute stress disorder in the DSM 5. Both descriptions are similar, but they do differ slightly on time frame, whereas one onset is 2 days post traumatic exposure for ASR in the ICD, and 3 days for acute stress disorder in the DSM. The DSM is the most evidence-based criteria that is used and collected using the DSM criteria and in most research studies. Acute stress disorder was introduced in DSM-4 in order to differentiate between short-lived distressing and impairing reactions to trauma from PTSD, as well to identify individuals who may be at risk for PTSD 1 month later. In the DSM-5, a diagnosis of ASD requires exposure to a traumatic event. Again, a traumatic event is exposure to death or threatened death, actual or threatened serious injury, or actual or threatened sexual violation. And the main diagnostic criterion requires meeting 9 of 14 symptoms. And it's important to remember we have 4 categories of symptoms. We have intrusion, which can be intrusive thoughts. It also can be nightmares or dreams about the traumatic event. Dissociative symptoms may be described as as numbing or not having emotions. And avoidance symptoms, avoiding things that remind the individual of the traumatic event. And again, arousal symptoms can be a negative affective state. Again, in order to meet criteria for a disorder, the symptoms have to be impairing and cause significant distress. And the diagnosis of PTSD includes the same exposure criterion as acute stress disorder. And in addition, it requires experiencing at least one symptom of intrusion, which can include recurrent distressing dreams or nightmares, intrusive thoughts or memories of the trauma, dissociative reactions or flashbacks, and as well intense psychological or physiological reactivity to reminders of the trauma or triggers. And also persistent avoidance of internal or external stimuli that are associated with the trauma. And two symptoms of negative alterations in cognitions and mood associated with the trauma, such as distorted blame of self or others, diminished interest in significant activities, detachment from others, estrangement from others, inability to experience positive emotions, such as emotional numbing, and then two symptoms of alterations in arousal and reactivity, which can include irritability, aggressive behavior, reckless or self destructive behavior, hypervigilance, an exaggerated startle reaction, trouble concentrating, or sleep disturbance. And again, differentiating from ASD, these symptoms need to be lasting for more than a month. They also need to be associated with clinically significant distress or impairment. Not all individuals will experience PTSD or have the same risk for the development of PTSD. Individuals experiencing the same traumatic event, again, depending on their resiliency factors, may or may not develop PTSD. So, here are some risk factors to consider for PTSD, and these are based on a meta-analysis of 64 studies and by Tricky et al. In 2012. And so pre-trauma risk factors for PTSD include females, individuals of a lower intelligence, lower socioeconomic status, pre-trauma life events, adverse childhood events, pre-trauma low self-esteem, pre-trauma psychological problems in youth and in parents. So these are some risk factors that would make an individual more vulnerable to developing PTSD after a trauma. Now, post trauma, things that would increase the risk of an individual developing PTSD include a peri-trauma fear, so that peri-traumatic reaction of fear, perceived life threat, low social support, the experience of social withdrawal, any psychiatric comorbidities, poor family functioning, and the use of distraction or thought suppression. So, individuals can be screened after a traumatic event to identify some of these risk factors as well. And so here are a list of differential diagnoses that should be considered. And certainly PTSD does share symptoms with a number of other conditions. And substance intoxication should always be ruled out as a cause and excluded from a PTSD diagnosis. But PTSD can present concurrently with mood and anxiety symptoms, and they may develop into a comorbid anxiety or depressive disorder as well. But differential diagnoses to consider, the number one is the adjustment disorder. Now, the difference between the diagnosis of PTSD and an adjustment disorder is that the adjustment disorder requires exposure to a stressful event rather than a traumatic event. And adjustment disorder does not specify required symptoms per se. And the patient's condition, though, should not be explained by another disorder. So, again, an individual with ASD or PTSD can have a comorbid anxiety disorder or depressive disorder. As well, it's important to differentiate between other reactions to trauma, such as dissociative disorders. And so really here is going to be just looking at the criteria, meeting full criteria. And certainly we do have other or unspecified um, PTSD that may be utilized as well. So studies have shown that PTSD symptoms in adults can improve mostly during the first 12 months following the traumatic event. And other studies have identified the chronic nature that PTSD can develop. And some individuals can experience significant levels of symptoms and impairments even decades later. Similarly, data among preschool children have also validated that course of PTSD can be chronic with little improvement um, over a 2-year period. Data among school-age children are mixed, where some have no long-term impact and others report elevated rates. So really additional research is needed um, as there's not a lot of data regarding PTSD in children and adolescents. In assessment of PTSD, there are a number of screening tools that can be used. It is important in general to ask open-ended questions rather than leading questions. And so we don't want to assume traumatic experience or traumatic responses. Rather, ask the individual to explain how they felt. How did you feel when this was happening? What were you thinking about? And it's important to use play and a playful approach when working with younger children. It's very important to engage caregivers and have a therapeutic alliance with both parents and the child, and assess the environment. Again, the child needs to feel safe in order to engage in any kind of trauma therapy. And it's important always to talk to the child together with the parents as well as on their own. And here we have a couple of scales that measure the peritraumatic reaction. And so one we have here is the peritraumatic distress inventory. And here this is going to help to identify children with risk factors for development of PTSD after a traumatic event. And so this is rated on a scale from 0, not at all, to 4, extremely true. And it's going through a number of um, distressful reactions, such as feeling sadness, grief, anger, feeling helpless, feeling guilty. So it's looking at all of those um, distressful reactions after a trauma. And then the peritraumatic dissociative experiences questionnaire, which will rate symptoms of dissociation from 1 to 5, actually, not true at all, to 5, extremely true. And so it's inquiring about those dissociative experiences, such as feeling disconnected, blanked out, spaced out, feeling like on autopilot, sense of time has changed, felt like things were happening in slow motion, felt unreal, felt like they were in a dream or watching from above. And so these scales have been validated in children, and they have been shown to identify later development of PTSD in children at higher scores. And so for treatment of PTSD, the goal is to reduce symptoms, reduce distress, and reduce impairment. So overall, that is the goal. Uh, Psychological first aid is a type of response to individuals after a disaster or some type of traumatic event. And by meeting their medical and safety needs and emotional support needs immediately following an event, is thought that could decrease later development of PTSD or even ASD. Critical incident debriefing is very controversial. In some workplace settings, critical incident debriefing can be helpful. However, for children, it has been found to do more harm than good and can be re-triggering or just um, expanding the reaction through the group process. And then there is evidence for exposure-based therapies in adults. So we don't really have a lot of research on their effectiveness in children. And pain management is very important for children after a traumatic injury. And good pain management, including opiates, may be needed for children or adolescents that are have experienced a traumatic injury. Otherwise, PTSD can develop. Benzodiazepines, however, are not helpful and are contraindicated for PTSD in children as well as adults. There's not a lot of studies regarding treatment of acute stress disorder in children and adolescents, and so most studies are inconclusive. However, trauma-focused CBT, narrative exposure, caregiver child interventions, and supportive counseling may be helpful. And the goal is to prevent later development of PTSD. SSRIs are indicated for PTSD, however, not for acute stress disorder. And the treatment of children and adolescents with PTSD will often involve an SSRI or SNRI, although the evidence is inconclusive. Benzodiazepines are not recommended. Antipsychotics occasionally with some severe symptoms because the side effects are significant. So generally they're best avoided. However, if an immediate response is needed, then short-term use of an antipsychotic may be warranted. And antiadrenergics such as clonidine or guanfacine are utilized at times for symptom management of the hyperactive HPA axis. And so they may be used, although not indicated, so off-label. And mood stabilizers also would be off-label, although one study did indicate that Depakote was helpful for teens with PTSD. Additional psychotherapeutic interventions do include trauma-focused CBT. Again, really needs to be implemented with caution. Other psychiatric comorbidities need to be stabilized first, and the child needs to be in a safe environment and need to have a heavy exposure to relaxation training and affect regulation, as well as assistance with cognitive coping skills. But in general, some psychoeducation about the trauma response on the body and the physiological response, as well as the psychological response, can be very helpful for children and families to understand why these symptoms are occurring. And then recreating the trauma narrative and doing some positive reframing or processing cognitive distortions, which often happens during a traumatic event. One of the most common cognitive distortions that needs to be corrected is the child feeling to be at blame or at fault for the trauma. And so, in vivo mastery of trauma triggers, that would be an exposure therapy. Again, conflicting evidence about it, but it can be utilized again in careful consideration. And increasing safety for the future and resiliency building is very important. Processing what ifs, safety planning, it can be very helpful. And always including the family. So, caregiver child, parent child sessions are going to be important.